So I'm Robert Roswell. I am the Associate Dean for Diversity, Equity, and Inclusion at the Zucker School of Medicine, Hofstra Northwell. I'm also co-director of the Cardiac ICU at Lenox Hill, part of Northwell Health. So again, thanks for joining. And I was looking at the talks that you had before. I think it's great when people ask questions and field your questions, because I think that might be a little bit more important than me just talking and not knowing, what sort of things that you would want to know. So just the way I have this framework when I think of critical care cardiology, in that, you'll hear people say CCU, which is the coronary care unit, or now people say cardiac intensive care unit. So that's how critical care cardiology came about. And I'll tell you a little bit more about critical care cardiology, but just wanted you to see the framework. And I know you've had a lot of discussions with other physicians, but how I think about how the medical field has really evolved in the past couple of decades. So this has always been true, that you could be academic, which is what I'll talk about, or you can be in just clinical care, just 100% dedicated to either hospital-based care or outpatient-based care, or you can be in the medical industry. And so that's really pharmaceutical, that is, drug trials, doing research with that's speakers, viewers, or you could also be in policy or in administration. So this is people who have MDs and become, let's say, CEOs or CMOs of hospitals. They can be CMOs, chief medical officers of insurance companies, or public policy. So you can take this and go to an advocacy group like the American College of Physicians or American College of Cardiology, and advocate for healthcare reform. And that interfaces with Congress and the government in terms of how we design and deliver healthcare. So there are all these different ways that MDs can be involved in again, in healthcare. And so it's such a diverse way of just thinking about the benefits of holding an MD: policy, administration, clinical care, industry, and there's even more that I'm probably not including in this Venn diagram. So I'm going to talk a little bit more about academic. And when I think about academic, sort of the academic physician, that really means that that's someone who's a little bit more dedicated to teaching, and so education, and also doing research. And just looking at the different types of academic settings that you have, you can really be outpatient, and I think you've had some talks from a lipidologist looking at preventive cardiology in an outpatient setting, making sure that you stay well in the outpatient setting and you don't come into the hospital. Then you could have people who are sort of on the hospital floors, who dedicate all their time there. And then I think you were just talking with a neurosurgeon. Looks like you were, spending more time in the operating room. And then you could also do things in the procedure suite, like interventional cardiology, interventional radiology, and all of those specialties. So at this time, I'll talk a little bit about the ICU and then the intensive care unit, and talk a little bit about how this is actually a new field of critical care cardiology. So for the cardiac intensive care patients. So critical care cardiology takes a whole bunch of things and puts it together. So it takes pulmonology, lung physiology, and mixes that with critical care. And critical care are, patients who are at the extreme of their diseases. They usually are on ventilators. They usually are on blood pressure support medications. And just looking at critical care and pulmonary critical care, and that's usually the combination that makes an ICU physician. Usually, as a pulmonary critical care doctor, takes care of the lungs, takes care if you have like shock from sepsis, from an infection. The other way you could do critical care is doing anesthesia. So a lot of these patients have respiratory difficulty that need, intubation with an endotracheal tube, and anesthesiologists can actually be critical care physicians as well. So you have pulmonologists are usually critical care anesthesiologists, and now what's coming into the fray is cardiologists who are actually trying to combine all of these things together and taking care of cardiac ICU patients who have very, very severe diseases. So when you think about that, what does that really mean? Like, who are we taking care of in the cardiac ICU? So a lot of our patients are those who have cardiac arrests. So if a patient was having dinner and then suddenly collapsed and people perform CPR, resuscitated that person, and they're still in a sort of semi-comatose state. That's a cardiac arrest patient, and we bring them to the cardiac ICU. One of our new technologies is somebody has an out-of-hospital cardiac arrest. We do something called target temperature management, which is actually cooling the body down, and so to protect their brain function and their neurons. And so that protocol actually, you cool them down from, let's say, normally it's 37 degrees Celsius is what we all are now. Hopefully that we don't have any infections. And we cool them down to 34 degrees or 32 degrees Celsius. And that just slows down a lot of the enzymes that are involved with cell death, especially when you have a cardiac arrest. And so that preserves brain function and actually has a mortality benefit. So those are some of the things that we do with cardiac arrest patients in the cardiac ICU. And there's a lot of ways of cooling patients. You can do it with a blanket, you could do it with ice pack, you could do it with an intravascular catheter. So many ways that you could cool down patients with cardiac arrest. So that's one of the newer things that we do, and that you see in cardiac arrest patients in the cardiac ICU. The other thing is cardiogenic shock. So when your heart is just really failing, when you're close to needing a heart transplant, or if you had a bad heart attack, you can go into something called cardiogenic shock. So we put in a lot of devices to help support the heart, and we actually put in devices that are temporary, very strong support mechanisms called left ventricular assist device. We can put in things called an Impella, which is another device that sort of supports the heart and actually can pump out a lot of the volume in the heart while your heart has to recover or you need a heart transplant. We also take care of patients who have very malignant arrhythmias. So we talked about cardiac arrest at the beginning, and that can happen because your heart goes into, a very malignant arrhythmia, like ventricular tachycardia or ventricular fibrillation, and you pass out suddenly. And that can keep on happening while you're in the hospital where your heart is trying to actually, poop out. So we take care of those patients with those malignant arrhythmias. Something more new that we've been doing, we've been taking care of patients who have really high pulmonary hypertension. So imagine that the pressure in your lungs and the vasculature in your lungs gets so high that it's actually now difficult for blood to pass through to go to the left side of the heart and to pump out to the rest of your body, because the blood pressure in your lungs are so high that it's actually causing blood to sort of back up on the right side of the heart and not even get through to get to the rest of your body. So we've been taking care of those patients as well, pulmonary hypertension. And again, these are some of the top diagnoses that we take care of. We also take care of patients who are in septic shock, but also patients who have acute coronary syndromes. So those are patients who have heart attacks, which we call myocardial infarction. So we can take care of those who have like a complete blockage of their artery or a partial blockage of their artery. And sometimes these acute coronary syndromes can actually cause cardiogenic shock. So not so infrequently, we see patients who have bad heart attacks, and we have to put in a support device to get them through cardiogenic shock until their heart normalizes and after the blood vessel is opened up. We also have aortic dissection, which is where you can have just a ripping through of the aorta, and that also is what we treat. You can treat that surgically, but if you need to be treated medically, you can come to the cardiac ICU. Also with malignant hypertension, so if your blood pressure goes up way too high, it can cause strokes. And so we do very invasive measures to control your blood pressure. And again, heart failure and also shock. So, and again, we take care of kidney insufficiency and all the things that intersect. But just so you get a flavor for some of the things that we do, I just want to list these things out for you. And so I put this up here just because of COVID, and you can see that we all work in cardiac, ICUs, and when COVID hit as this, continual health crisis, everyone who can take care of a critical care patient was called to task. So regardless if you were a neuro ICU or a neurointensivist or cardiac intensivist, pulmonary critical care, everyone was called to take care of COVID patients. And I just put this up because this happened to our medical students graduated early. And regardless of where you are in medicine, everyone was taking care of COVID patients. And hopefully we don't have too much of a national research back in New York, but literally everyone who could provide care was providing care to COVID patients. And so again, just looking back at the intersection between critical care, cardiology, pulmonary critical care, everyone was doing these things, and we were just learning about new ways to ventilate patients with COVID who had acute respiratory distress syndrome. So even in the cardiac ICU, this is a patient here who was COVID positive and had really severe pneumonia, and the type of pneumonia that can be severe with COVID is ARDS. And so this is a patient who is on the ventilator here, but we had to do different types of maneuvering because even though these patients are on the ventilator, getting 100% oxygen through their endotracheal tube, it still wasn't enough oxygen to give them even at 100%. So what we had to do is start moving these patients around and putting them prone, which is on their face down. And that could move around sort of the lungs and the blood vessels in the lungs to sort of move things around to sort of find spots where there actually was blood flowing so you could actually ventilate the patient and oxygenate the patient much better. It's a more complicated thing to talk about, but these are some things like, regardless if you're cardiac critical care or anything, we all were doing the same thing. So I hope that gives you just a quick flair of what cardiac critical care is like. And I just wanted to put that out there and then start answering your questions because I'm sure you have other things that we should talk about instead of me going on. So let me just stop and just see what sort of questions that you guys have.
I just opened the chat up, so questions will start coming in.
Got it.
Maybe what would be best to start with would just be to tell about your story, like how you got to where you are today, your journey through medicine.
Sure, and I think that's a good thing. So I think my story, as I would say, dating back to high school, was when I was interested in medicine because it was brought to me. I was actually in a program in my high school, and they were introducing pre-med curricular in science, and I always excelled in science. And so I decided to major in high school in biology and chemistry and start taking a lot of AP classes and really liked science. And I didn't know whether I was going to do a PhD in one of the sciences. And what I realized, which is what I think a lot of people don't realize, is that medicine is a combination of really science and the social sciences. And I liked the communication and humanities and actually figuring out social issues and how that intersected with scientific or basic science issues. And so that's why I sort of went on my path to medicine. and went to college, and of course went to medical school. And after medical school, I was trying to decide if I was going to go into cardiovascular surgery or if I was going to stick in cardiology. And I think, again, just thinking about how I like to interact with people and hear their story and see if I could try to fix their heart from that perspective was how I went through and decided to be a cardiologist instead of a cardiovascular surgeon. So instead of spending time in the OR, was spending time more so on the floors with patients. And so I went to University of Maryland for undergrad. I went to NYU for medical school, and then stayed at NYU for residency in internal medicine. And then I was part of and then became a chief resident there. And then went to Georgetown in DC for cardiology training. And so hopefully you've heard some other people talk about their training and their pathways. So after medical school, 3 years as a medicine resident, 1 year as a chief resident at NYU, and a chief resident is just a special year where they choose sort of the top residents to lead and teach the classes, like doing morning rounds, et cetera, and be a little bit more of an administrator. Then I went into cardiology at Georgetown and was a chief fellow there as well, and then came back to NYU at that point as associate director of the cardiac care unit. And then I transitioned on to Northwell, being the associate dean and also the co-director of the cardiac ICU at Lenox Hill. So that's a little bit about my path, and always wanting to be, I think, interacting with patients was one of the highlights. And that's why I have the path I have, and instead of, let's say, just 100% clinical. My day, and I think I saw one of those questions, my day is sort of rounding in the cardiac ICU 1 week out of the month. The other weeks, I'm an administrator, sort of getting the curriculum set for the cardiology fellows. And then also I do research in cardiac arrest. I do research in STEMI, or acute cardiac care issues, and trying to publish all that data. And then also my dean title is the Associate Dean for Diversity, Equity, and Inclusion. So anytime diversity or equity principles sort of intersect, I will publish on those as well. And then teaching. And then a lot of my time is teaching at the medical school. And I think for me, it's pretty impactful because not only do I like taking care of patients and research and look at the best way of taking care of patients with cultural humility, but it's also teaching the generations to come what I think are the great ways of taking care of patients. And so I hope that sort of answered a little bit about who I am and how I got on my path. And now let me try to tackle this chat because it seems pretty, it's moving here. So I think in terms of, someone was asking about physiology studies, talking about reducing oxidative damage, which is what I was talking about before. So more complicated with cardiac arrest patients. You know, you have programmed cell death and you have oxidative damage to cells. And that's a big way that we think is how you don't regain your neurological function after a cardiac arrest. And so there have been a lot of things tried in terms of reducing oxidative damage, these free radicals and programmed cell death and apoptosis. But when you try them out clinically, so I haven't seen anybody use malonate, but when you tried out a lot of things clinically, nothing really seemed to work. So I think when we tried doing temperature control, it seems like there's so many different pathways involved with oxidative stress, free radicals, everything. Cooling down a temperature controls a lot of several different pathways. And that, I think, has shown that that is a mortality benefit. And so let me look at some other stuff. So I think we talked about how we get here. I think challenges based on a daily basis. What I wanted to mention, I didn't mention, is cardiac critical care is a very new subspecialty. So we don't even really have an organized way of how cardiologists can become cardiac ICU physicians. So one of the challenges that I had was sort of putting together what I think a cardiac ICU doctor should know is to know the vents, know critical care, know pulmonary critical care, and then put that all in a mix. And so the challenge is that like this field is so new. Hopefully by the time that you all come into the fray and you become physicians, that it will be a lot more standardized and normalized because a lot of trainees right now are looking to learn about cardiac critical care. It's so subspecialized and there's no real formal pathway that it's really difficult to bring people on. So I think that's one of the challenges. And in terms of diversity, I think diversity is defined as a lot of differences. Like it could be racial diversity, it could be ethnic diversity. And the diversity, when you think about it, really depends on where you are. So if you are in Alaska, the diversity or what should be the diversity of, let's say, medical schools or hospital physicians or the infrastructure there will be very different from the diversity, let's say, in New York City or Boston or Chicago. So diversity is really a lot of differences, but it really takes into consideration what the population is around. So if you're a Greek student, it depends on the population around where you are. And are we talking about, let's say Southern Europe and what's going on there, or versus America and diversity there. So each medical school really can define diversity, how they feel. And usually when we're talking about underrepresented people in medicine, historically, those usually are Black, Latin, Pacific Islander, Native American, and hopefully I'm not forgetting one. But that's usually the historical underrepresented people in medicine. And so a typical day for me is, let's say it's 1 week with taking care of the patients in the cardiac ICU that's one week. So that's just taking care of patients. And I think importantly, talking to their families, talking to the patients and with their families about stuff and their diagnoses. And I think it's hard when, let's say, for example, there's a cardiac arrest, because we talked about that in the beginning. So for a cardiac arrest, sometimes you just don't know if the patient will wake up or not. And that is one of the most difficult conversations to have. Like for example, if you have a 50-year-old person who has like a bad heart attack and they had a cardiac arrest at a restaurant, and you did the cooling protocol and you rewarm them, basically your fingers are crossed. You have some predictors to say, well, did they get CPR right away? How long were they down? What do their labs look like? Those are some predictors, but they don't predict 100% or really close to 100%. So some of the difficulties in that day is having conversations with family about chances. Let's say if it's 30 to 50% or 5%. How long do you continue to wait for that person to wake up? What time is sufficient that you say, I don't think they're going to wake up and I don't think they want to live attached to a tube, and sort of disconnect them and let nature take its course. So those are particularly challenging times. And I think I've been doing this for over a decade. So I know the path it usually takes, but every now and then I'm always surprised. Like, you never know. There was a patient that woke up on day 50 and, went home, and you would never think that. So I think medicine is very, very humbling. And let me continue to talk about the typical day. So after rounding, if that's the whole week, there also, since I'm also into administration, I would try to get or see meetings about protocols or something else that we need to do in the hospital, and having meetings around that. And then the next couple of weeks is really planning educational curricula for the cardiology fellows, for the internal medicine residents, and for the medical students. And so that the other time is dedicated to doing that. And within that time, I'm also trying to do research. So a couple of the research projects I'm looking at right now is looking at, structural inequities and out-of-hospital cardiac arrest, looking at the best ways to teach people in terms of microaggressions and medical education, and also looking at blood transfusion cutoffs in patients who have myocardial infarctions or heart attacks. So you can see I'm involved with a lot of different things, and for me, that's really fun and good that I can do research. I can do medical educational research. I can do diversity research. I can do cardiology research. I can do curriculum development, teaching, all of that in one. So let me go down just a little bit. So what sort of procedures do we perform so in the cardiac ICU, I mostly put in central lines. So those are bigger IVs that you put in. We put in pulmonary artery catheters. So when you're very, very sick, like when I mentioned with pulmonary hypertension, that you could actually measure the blood pressure in the lungs. So we put in the special catheter to do that. We also put in what you call as transvenous pacemakers. So pacemakers that can go through the neck and go into the heart and to get you out of those malignant arrhythmias or to temporarily pace your heart. We also take care of patients who have something called an Impella device. And those are devices that can support the heart. And I wonder if, I'll see if I could find a picture of the Impella to share with you, because I think it's a very fascinating machine, and it just goes in and really helps unload the heart. And it depends. Usually post-op patients don't come to the cardiac ICU. They usually go to the post-op surgical ICU. And so people are asking about COVID now and how that impacted the cardiac ICU. As mentioned before, COVID just took over our whole hospital. So every patient in our hospital was, in our ICUs were COVID patients. So we actually had to build more ICU space. And I don't know if you've talked with some of your other panelists, but we have 40 critical care beds, and we had to build 96 about critical care beds. And in the peak of the COVID pandemic, we had 96 COVID only ICU patients. So that is how it really impacted the cardiac ICU. The whole hospital turned into a COVID ICU hospital. And so, as I said, if you were cardiac ICU, pulmonary critical care, or anesthesia, we were all doing the same things. And then the question is if COVID really, if patients with that presented with increased troponin levels as a cardiac enzyme marker, and they typically did, but we didn't check in a lot of them. And the question always is, when you're checking these really sensitive biomarkers, I think you have to have a really good reason to check them, because if you check them and it's positive, then the question is, what are you going to do about it? And with MIs, you have to really figure out if it's a demand mismatch. Let's say, your artery is mostly open, maybe it's stenosed like 20%, but because of COVID, or you have a fever, or your blood pressure is a little bit low, is the blood not enough going through that vessel and causing damage to the heart? And if that's the case, what you would have to do is just undo the damage, which is treat the COVID, treat the blood pressure, et cetera. There are rare cases where we saw that somebody had actually a blood clot or a thrombosis in one of their heart arteries during COVID. Most of them were negative. What we saw is that people were afraid to come into a hospital during COVID. And now that COVID is over, we saw that many people were staying at home and dying of MIs and dying of arrhythmias instead of coming to the hospital. So that was one thing that we saw and that we're seeing a lot. And if you look at, and the studies that are being published now, like if you look at JAMA Cardiology, is showing that there's an increased risk of death from MI post-COVID, meaning that people actually stayed too long and didn't come in and seek cardiac care during the pandemic. So I think there was a question about, let's try to use this. Are there advantages for MD, PhD? Oh, okay, got you. So is there any advantage of doing an MD, PhD if you're interested in research, or just doing an MD? I think that's a great question. And I think to really understand it, you know, I always think of MD, you could just take, you know, have clinical care, but then you could actually be an MD with a master's in epidemiology, and you can focus a lot of your career on doing research and writing grants. And then you can do a lot of translational stuff as an MD, PhD. So really bringing that benchtop information and trying to translate it to clinical care is where you're doing your MD, PhD. And again, PhD is really looking at a deeper level of basic science. I think there are a lot of ways that you can do research, and it just depends on how you feel like you will be dividing up your day. So for an MD, PhD, you should be thinking that you'll be spending the bulk of your time in your research lab. So usually MD, PhDs are somewhat 80-20 or 90-10. So meaning that you're doing research in your lab 90% of the time, and then 10% of the time clinical, or 80% of the time in your lab and 20% of the time clinical. You could actually do that as an MD as well, but just knowing the different ways that that's split up, MD, PhD, you are really expected to take and be in your lab that much time. So it really depends on you know, how you see that splitting up. But you can definitely do a lot of research with just an MD. And the favorite part about working in cardiac ICU, I think, it's the fast pace. And I think all of these specialties that you're hearing, again, I was listening to a little bit of the neurosurgeon talk. A lot of it depends on your personality and how much attention you pay to detail, what kind of lifestyle you'll have. You know, I always think of an emergency room physician who really sees patients in that snapshot. So usually ED shifts are about 10 to 12 hours, 3 times a week. You see those patients, you don't follow them ever again. That's it. And if that's the lifestyle you want and feels good to you, I think you should do that. There's also primary care physicians compared to ED. There's primary care physicians who have their patient panels and follow them like for the rest of their lives, right? So there's an ED physician who follows them really quickly, primary care who follows them for the rest of their lives. And so I think for cardiac ICU, I like that sort of snapshot where I get to take care of them when they're the sickest in their hospital stay. And so I like doing that and discharging them. I think, and this is a sadder point, is I think I relate well to people, and especially if they are in a very difficult predicament. I like relating to them and helping them understand the sickness and the severity of sickness in their loved one's disease. So let's say, for example, if they have a cardiac arrest and they're not doing well, and let's say this is week 3, that they're still in a coma, I really appreciate getting to sit down and talk to a patient's family and explaining to them human to human what's going on and helping them through like very, very difficult times. And I think, and I don't know if favorite is necessarily the right word for that, but I think it's a very rewarding part of working in the cardiac ICU, is just really helping people through and also being there for people to say goodbye to their loved ones. And again, it's not like my favorite thing to do, but it's very rewarding. Like there's a patient who had a cardiac arrest after a helicopter crash and drowned in the East River in New York. And she was from New Zealand, and it was something that was in the papers and the news. and her mom came, and we just all realized that this is not how the daughter would want to live. And so it was time to say goodbye. I think having that conversation, holding hands and just saying goodbye to that person with their loved one and supporting her mom and the patient peacefully, that was so rewarding. To this day, she emails me, happy, holidays. And when I actually went to New Zealand one time, we actually met up again, and like her pictures are on the wall in my office. And so I think having a particular impact on people, and I think cardiac ICU is a great way to do it. And so I think that is the I think the most rewarding part. I think any adversity that I've faced in my journey through medicine, I would say a lot of it is probably microaggressions that I felt throughout medical school and throughout training, and also from patients. I think as a Black medical student or a Black physician, it's pretty difficult when you're like one of 100 and patients don't recognize you as a physician or someone who should be there. And that is pretty challenging. And that is something that probably is what put me on the road to being Associate Dean for Diversity, Equity, and Inclusion, and just teaching people how to navigate those tough waters. But those are some of the pretty difficult, I think, journeys that I've had in medicine. And yeah, I think someone's asking about, as we were talking about microaggressions and how they weigh on you, I think someone was talking about mental health and a wellness amongst physicians. And I think that's an important point because it's a double-edged sword, because physicians, say if you're, especially if you're in the ICU, you have to learn how to distill what's going on in your personal life versus what's going on in your professional life. And that can be very hard. And your job really is to support the patients and their families. And so anything that will weigh you down is very, very difficult, because you can't bring that to the patient's family, or if you're chatting with the patient's family, you can't let that weigh you down too much as an individual, but you also have to let it affect you so you can really be and reflect some empathy in those interactions. And so what I found pretty helpful is a lot of my friends who are gastroenterologists, who are critical care physicians, we all talked to each other. We talked to each other through the COVID crisis and making sure that we were all well, and that if we saw someone who was really suffering, that they got referred to appropriate therapy or counseling, because we did go through a lot. And I'll just share with you one quick story is in the ICU, we did allow patients' families to come in if they were going to pass, if not do well. And it was up to the family. They can come in or they can stay at home. But this family, they decided that they wanted to say goodbye to their grandma. They wouldn't come in. So it was up to us to hold up the phone and FaceTime for them to say goodbye to the grandmother who was passing from COVID. She wasn't doing well and she was about to die. And we had to hold up the camera, and it was there was a grandbaby that was born while the grandmother was in the hospital. And so I had to stand up there and watch the son say, hey, Mom, we love you. This is your granddaughter. You haven't met her yet, but you'll see her in heaven. Just say bye and we love you. And so those things are really tough, to see people saying goodbye through a phone and saying that they will meet their, grandkid in the afterlife. And so it's really tough, and you really need to talk to people and really just really get your thoughts out there, because it can weigh on you. And again, COVID was tough. I tell people it was the toughest part in my whole career. Even as a medical student, ICU, it was tough. The amount of alarms and sick patients that were all over the place. Literally, you would start your shift and you would not sit down for like a good 8 hours because patients are crashing repeatedly one on top of another. So thanks for that question. And let me see. So we have patients with ventricular septal defects or atrial septal defects, and we do see that in as cardiologists in the ICU. We don't see as much complex congenital heart disease, but we know ASD, atrial septal defects, and VSDs. We see that a lot, and I really like congenital cardiology, and I don't know if you'll be talking with a congenital cardiologist. They are some of the smartest people. They understand embryology really, really well. They can tell you about these VSDs, ASDs, different types, and how we deal with them. But it's just so amazing when we get to talk with congenital cardiologists. I just think that they're just such smart people, and it's funny because when you understand how complicated a field is, and you wish you understood it better. Uh, but I still like it. I don't understand it as well as they do, but I think it's an amazing field. And I think we talked about some of the emotions involved with the ICU, and I think just the other thing is just sometimes unplugging from work, like watching sometimes something silly on TV when you're dealing with a lot of stress at work is a great way for me personally to move forward and reflect. I think looking at, unfortunately, we don't work a lot with the engineers. And so when I was applying to undergrad, I was thinking of doing biomedical engineering, and gosh, that would be so lucrative and so fascinating right now with all these devices that are coming out. They are based on biomedical engineering, looking at flow, and it's just an amazing field. But yeah, we mostly work with the reps, et cetera, after these things are developed. So tactics for giving bad news, I just say it. If there is a patient didn't do well, I just make sure that everyone is seated. I think you have to be mindful that people take bad news in different ways. Faint, pass out, scream, cry, need a walk, need a hug, need to get out of the space, need to have someone around them. So it's really getting to know that person and just figuring out how you're going to set up the environment to give them the bad news. And that's usually what I do before is, and I see how they interact, who they want to talk about stuff with, and make sure that they have a supportive environment. And cardiology fellowship is usually 3 years. And if you want to subspecialize, there's another year on top of that. Like if you want to do interventional cardiology, or if you want to put in pacemakers and do electrophysiology, then there's extra years. So for chief resident, I think chief residents are different too in different specialties. So I can tell you chief residents for surgery and OBGYN, a lot of the surgical subspecialties, the chief is your last year of residency. But in medicine and pediatrics, it's actually an extra year. And the way they choose it is that people apply, and the program directors choose. They give you like an interview, and you practice teaching, and again, you act as that liaison between the house staff and the residents and the administration. I think it's fascinating for anyone who wants to go into administration or leadership position because it gives you an eye straight into all of that sort of stuff. And someone asked about the ICU and that aspect of cardiology and dealing with patients with more chronic or long-term issues, which I think is a great question. And when you're looking at long-term issues, that's again longitudinal follow-up. And ICU is just looking at that snapshot while they're in the hospital. So it's great for me in terms of my personality type to just see them in that snapshot instead of following up with them in their longitudinal issues and medication management and all of that other stuff. Somebody was asking about books I would suggest, but I don't know if you mean cardiology books or books in general. So maybe specify, and then I'll try to answer. I'll look out and answer that one again. And I hope I answered the question about how people split their time. So you can split your time as the dean doing educational curricula 50% of the time, and then 30% of the time you're working in the cardiac ICU, and then 20% of the time you're doing research and stuff like that. So I think you should know that a lot of physicians, they have time split in different places. So that's how I do it, and that's how everyone could do it. And I think, yeah, balancing personal life and working and all those sort of things, I think it has to be to each his own or her own. You have to figure out what works for you. And I think this being a clinical care, research, and education is part of this tripartite mission of academic medicine. And I just think it just resonates well with me that I always want to interface with patients, and that I told you before, the empathy, the human interaction, I think that is critical to my well-being and my joy as a physician. But also, I love to be asking, what is the next question? What is the next step in this field? Let's get more involved with research and figure out what questions we need to ask, and let's start answering them. And then after doing that, I love teaching about it and to make sure that whatever I've learned really impacts future generations. So I love all of those, and the way that I have that set up and the way my schedule is set up, it works out pretty well. And so I was looking at how is it in medical school being a minority and dealing with interactions that we less, trying to read that question one more time, see if I could get it. And, that we're less than pleasant. Okay, got you. Sorry about that. So I think, it is harder, I think, with some of the interactions being less pleasant. But I think for me personally, I saw a lot of, I think, support from interesting players in the hospital, like the support staff who were there, and also patients who are mean to a lot of people, not only minorities, but patients who could be mean to women, patients who can be mean to a lot of different types of people. But also there are patients who are just so supportive. I remember a couple of patients that I'll never forget, and they were just like, I never thought I would sit down here and just randomly be with a doctor like you. It just brought tears to my eyes, and this is the patient talking, that I see from the civil rights movement and all of this sort of stuff, that I actually get to see a Black physician today. Thank you for being here. So I think it's those little jolts of energy and reaffirmation and support from the community was amazing. And that's where I found the resilience in terms of the community and the support, and it just made for a much more pleasant situation. So there always has to be some place that you find support when you feel like you don't belong, or things are made a little bit more difficult, or people don't understand you from your cultural perspective. I think those are really important. And cardiac trauma cases, yeah, we deal with cardiac trauma cases, especially if they're non-surgical. We can support them in the cardiac ICU, but if there's a surgical intervention, then of course, then they have to go to the cardiovascular surgeons. And I think the person who's asking about research, administrative work, and physicians and leadership roles, I think is really important. And again, depends on when your drive in life, but in a leadership role, I think you have a responsibility to advocate for what you see as the best step forward for medicine. So if you see medical education not working well, and physicians still holding biases, implicit biases, and how that's affecting health outcome, you have to try to advocate for that to be different. Also, I think physicians are too quiet. I think if you look at the structure of medicine and healthcare delivery in our country, it's pretty in it's in a pretty desperate state right now. And I know people think about insurance companies and how we deliver healthcare, when we've been trying to make sure that we deliver healthcare to everyone through whatever mechanism, but we try to do it with the job. But now look what's happened with COVID. People don't have the jobs, and so how are we going to get healthcare? And that's also bankrupting healthcare systems and hospital systems. So I think we really need to look at our healthcare structure to make it more equitable and more functional, because I think it's just really collapsing, and I think physicians have been too quiet about that for too long. And I think there are many ways that you can there are many ways that you can talk about putting your research, whether you're biology, computational, um, biology. You could actually, a lot of stuff that we're looking at now in medicine is predictive analytics. And so regardless of whatever your field of specialty or whatever you studied undergrad, there's ways if you want to sort of delve more deeply into that and apply that to an MD. We have some more specific questions about like shockable versus like non-shockable rhythms. So shockable rhythms, they usually have better prognosis. So shockable rhythms are particular rhythms where you have, let's say, ventricular tachycardia, where the bottom part of the heart is beating too fast, or ventricular fibrillation, and you can actually do something called a defibrillation, where you see on TV where they shock someone and the heart restores back into a normal rhythm. But there are other non-shockable rhythms where you can see either nothing, like a flat line, or a rhythm, an electrical rhythm, but there's no actual blood pressure. And those are not rhythms that you can shock. They do nothing. And so one of my pet peeves is when I see on movies, there's a non-shockable rhythm, and the doctors are coming in with their pads and like clearing and shocking it. And it's clearly not the right thing to do, but what can you say? If you're thinking about healthcare policy, and someone says not worth it, right? And I think this is what we were talking about before. The best people to advocate and change medicine is those who really have a firm sort of grounding in structural policies and public health. Because I think for far too long, physicians don't know about a lot about public policies and just sort of continue to work on. And this healthcare system is not working well. So, and it also is good to come from the perspective of an MD trying to fix public policy, because I think as a politician or someone who knows law, it is very difficult to really understand the nuances of what needs to be done. You're welcome. So when COVID-19 patients went into cardiac arrest, nothing really shifted that much. We just started treating patients, they're COVID, they were isolated, but nothing really shifted. This is a more medical question, looking at STEMI, non-STEMI as a false dichotomy. So STEMI usually means that you have like a full 100% blockage of an artery, ST elevation MI, whereas a non-STEMI means that you don't have 100%, but you have a high percent. But if the evidence of their heart being injured is quite great, and they're losing a lot of of myocardium, should they go to the cath lab and have their heart artery opened up earlier? And I think the answer is yes. So I don't think it's a false dichotomy. It's a way of characterizing things. But STEMI is absolutely an emergency. You should go and get your heart artery opened up within 90 minutes. Non-STEMI, remember, you would have to wait to see the evidence of a high amount of myocardial loss. And by doing that, as soon as you see that, and if the troponin elevation is really high, those patients go pretty quickly to the cath lab. Is it true that CPR isn't actually very effective in real life and can harm the patient? No. CPR is very effective in real life. And we've published, if you look at Carlos Alviar, Alviar, has published on actually the fear of actually doing CPR on a patient and what that does in terms of its morbidity and mortality. I can tell you, seeing a lot of cardiac arrest patients, the ones who do the best are the ones who get CPR quickly. And we believe in that so strongly that we worked really closely with the American Heart Association to ensure that people knew about hands-only CPR, and that if they didn't want to do mouth-to-mouth, you don't necessarily have to do that, but you could just really continue to do hands-only CPR, because we saw it was a week in the cardiac ICU where we saw 4 patients who were 40, 42, 44, and one was 50, come in from a nearby office where no one did CPR on them. So CPR is really, really important. Contact details, if you can write this down, maybe I can put it in the chat while we go on. And okay, somebody answered the questions about the CPR. This is very, very, very effective. But I think there are problems with misperceptions about that. I probably shouldn't have done that because I lost my place. Oh no, almost here. And I know we're running out of time, Joshua, right? So maybe one more.
Yeah, that would work. Do 1 or 2 more questions.
Let me just try to get one more question. I think this one, what do you like to do to wind down after an emotionally challenging day? Just relax with like a glass of wine or Prosecco and just watch junk TV and get my mind out of just thinking about the horrific things and the things that just had happened in that day, because it can wear you down, and you have to feel some sort of relax. You can't think about these things all the time. And even if patients or people around just feel uncomfortable with you around, whether you're a woman, whether you're a minority, whether something else, you have to interact with them, and you have to make them feel at home as well, and you do the best that you can, because diversity is important, because that's how we move things forward, is having different minds, different people coming together to solve really difficult problems.
Thank you so much for joining us today. This was a great talk, and it was awesome that everyone got to get their questions answered. So thank you for that. Just as a reminder to everyone, there is Tumor Talk tonight with Dr. D'Amico. So the information for that's in the Facebook group if you want to join. But thank you again for Dr. Roswell for joining.
I'm glad it didn't pause or freeze.
Yep, it worked great. Have a great day, everybody.
Bye-bye.